We've been rather fortunate, I think, over the past few years in this exciting field to have several big trials telling us which patients will benefit from the use of CRT devices. And I'm not going to go through all the trial data, but in 2009 we had a seminal trial, the MADIT CRT trial, which showed us that if we implant patients with milder heart failure, and in this trial they recruited patients in NYHA class 1 and 2, mostly in class 2, that these patients derived benefit from CRT. And then a year later, the RAFT heart failure trial also showed the same thing. RAFT recruited people with NYHA 2 and 3, but the majority in class 2. And that changed the sort of landscape of patients we selected to put CRT devices into. And as a result of that, the international guidance followed. So in 2012, the ACC, AHA-HRS, published an updated guidance in their guidelines, and then following that, the European Society for Cardiology also updated their guidance. And these documents are very clear and very useful to look at if you're going to look at who you think will benefit from CRT. And following those guidance, there was a trial called the ECHO CRT trial, and Kenneth has already alluded to this, to show us who not to put devices into. So what ECHO CRT told us is that if you've got a narrow QRS complex, in general the patient doesn't benefit from a CRT device. In 2014, I'm in the UK. We had an update in our National Institute for Clinical Excellence, or NICE for short, guidance, which brought together two previous guidelines of how we use defibrillators and how we use CRT. And because we're in Spain, in Seville, and we all will agree it's very, very nice. It's not very sunny outside today, but it's a very nice place to have a conference. I'm just going to talk you through some of the ESC and the key points from their guidance. So when we talk about international guidelines, we talk about a class of recommendation. And just to remind you that a class 1 recommendation is really what we're looking for in the guidance. If the guidance says a class 1 recommendation, there is evidence and general agreement that the procedural treatment, in this case CRT, is beneficial in the group of patients. Class 2A, there's a general opinion and evidence in favour of the therapy, and in Class 3 recommendation is that actually there is some evidence that the therapy should not be used in that group of patients. And guidance, international guidance, also talks about level of evidence. Level of evidence A is what you're looking for. These are big, multiple randomized controlled trials or big meta-analyses, down to level C, which is generally a consensus of an opinion or some case studies. So let's look at the ESC guidance very briefly. What are the indications for people with sinus rhythm? Who should we be implanting cardiac resynchronization therapy? It's quite straightforward, I think. Class recommendation 1, level of evidence A or B. So if you've got somebody with symptomatic heart failure, class 2, 3 or 4 heart failure with a left bundle branch block pattern, a QRS duration of more than 150, that's a no-brainer. And if you're between 120 and 150, I think there is a general consensus, and the guidance backs this up, that we would implant a CRT into those patients. It becomes less clear, I think, if you have patients with a non-left bundle branch block pattern. So what the guidance says is they have a class 2A recommendation if you've got a non-left bundle branch block pattern with a broad QRS duration. And I think we all probably would insert a CRT device in these patients. And then if your QRS gets narrower, if you're between 120 to 150, this is a little bit of a grey area, and I think we shouldn't just follow guidance, we should assess each patient individually. What we do know, and what the guidance does state, is that you shouldn't embark in CRT therapy in patients with a QRS duration of less than 120 milliseconds based on previous trials. What happens if you've got atrial fibrillation? Again, this is a big area of discussion at the moment. The ESC guidance tells us that if you've got symptomatic heart failure in class 3 or 4, and you've got a broad QRS duration of more than 120 milliseconds, then it would seem reasonable to insert a CRT device, recommendation class 2A, if subsequently you ensure that you can achieve as near as you can to 100% biventricular pacing, either with optimization of the medical therapy or indeed an AV junction node ablation. What about upgrading pacemakers? I think it's now recognised, and the guidance echoes this, that if you've got somebody with a normal bradycardic device, be it just a simple standard pacemaker or an ICD, and you have a bad ventricle and your percentage rate of pacing is high, that induces a left bundle branch block pattern. That's not very good for you. And I think we're all in agreement that if you're symptomatic in class 2 and 3 and 4 heart failure, we should upgrade the device to a CRT device. The European guidance also recommends that if you have somebody with a reduced ejection fraction, that you are going to pace anyway for another indication. For example, if they've got secondary AV block, then you should maybe think about the addition of a left ventricular lead instead of your standard bradycardia pacing therapy if they're going to pace a lot. It would seem reasonable at de novo implant to offer them a CRT device. So they're the guidance for CRT. What about, do we insert a D with that? Who needs a defibrillator as well as their CRT? Well, as a class 1A recommendation, if you already have an indication for an ICD and you're going to embark on a CRT device, they would recommend that you put a CRT-D in. So, for example, if you've had a previous cardiac arrest or you've got some evidence to show some unstable hemodynamic ventricular rhythm. And then they point you to a table to look at the balance of who you would put a CRT-P in versus a CRT-D. And I think this is really good clinical common sense, to be honest. And I think this is where we need to treat our patients as an individual. So in the table, it says factors favouring CRT-D. If you've got a life expectancy of more than a year, your heart failure is stable with less severe symptoms, it says NYHA2 in the table, ischemic heart disease with a lack of comorbidity, it would seem reasonable to put a CRT-D device in rather than a CRT-P. And on the left-hand side of the table is if you've got advanced heart failure with renal problems, comorbidity, frailty, it would seem reasonable to insert a CRT-P than a D. So I'm based in the UK. Manchester is in the northwest of England. It's not as nice as Seville, it has to be said. We have the NICE guidelines. Now, in the NICE guidelines, there's a rather nice table that looks at NYHA class across the top and QRS interval and left or non-left bundle branch block pattern down the side. And that table, I think, is a good aide-memoire rather than trying to remember all the European guidance. And if we just take a random patient, for example, if we have a patient with heart failure with class 3 symptoms, we have a non-left bundle branch block pattern, and the QRS duration is broad, but it's not that broad, say at 130 milliseconds, then we can go to the table, actually, and say the NICE guidance recommends that you should consider an ICD in that patient. Now, there are some differences between international guidance, and you probably can't see all this, but again, let's go back to that patient. Class 3 patient, non-left bundle branch block pattern, a modest QRS duration of 130 milliseconds. In the UK, we've already seen the NICE guidance would recommend an ICD therapy. In the ESC guidance, it says you could put a CRT-P, this is what the ESC recommends, or a CRT-D, or an ICD. And it's the same in the US guidance. That's not to say that the guidance is confusing. I think that's what it's telling us, is that good clinical common sense is needed when we assess our patients for heart failure and select the appropriate device. So how we're doing across Europe, what do our implant rate looks like? So this is the CRT implant rate. The average Western European average total is 119 per million. So you can look where your individual country is down the left. I've highlighted the UK. We're slightly above the European average at CRT implant rate. And then if you look at high-energy devices, ICDs or CRT-Ds, the average is 267 per million, and the UK is a little bit behind the average. And these data were before the NICE guidance were published, and certainly in my practice, the NICE guidance has probably allowed us to insert more ICDs in people. So, I don't know about you guys, but I find it quite difficult to remember all this guidance. I find it quite difficult to it's quite straightforward, I think, if you've got somebody with a left bundle branch block pattern in sinus rhythm with a QRS duration of 180 milliseconds. That's quite easy to do. Okay. But it's where the grey areas come in the guidance. So I think as an aid memoir, it's always good to have your memory jogged. But also, I think that it's good that we follow the guidelines to ensure consistency and adherence across Europe and across the world. There is an internet-based tool called Screenlink, and this symposium is sponsored by Medronic. Medronic are behind Screenlink, and what you do is you put the patient data into Screenlink, and you can do this from anywhere you are in the world. You just select your region, and it will tell you what the appropriate guidance, your local guidance is. So can I just take a show of hands in the audience, please? Who first of all, has heard of Screenlink? Put your hands up. Okay, who's actually used Screenlink? So that's quite interesting, only a few people. Who's actually got a Screenlink app on their tablet or mobile phone? Not many. I have. There it is, the Screenlink app there. There's also an app for the heart failure conference. Did you know that? That's a very good app. Saves you lumbering around that bag with all that stuff in. And you might think Dr. Williams is very academic on his mobile phone. Look here, there's a CHF trials app. There's a Seattle heart failure model app. What you haven't seen is the next page of my telephone, which my kids spend half the life on my phone. Not on that app, but on these apps. So what do we do in Manchester in the UK? Note that it's still raining by the hospital. That's a live video web link. Well, we would use Screenlink, and we use this a lot in our practice because we have patients with heart failure who are followed up in community heart failure clinics. We have nurse-led clinics, and we want to keep evaluating if a patient will require a device, if that device therapy is good for them. So we would use Screenlink in Manchester to ensure referral of the right candidates for CRT. So hopefully the technology will work. I'm just going to give you a quick demonstration of Screenlink. And we're just going to put a random patient's details in. So when you click Screenlink, I've gone to the UK, so I'm going to demonstrate what we do in the UK. But as you can see, you can be connected to the European guidance, or the Australia guidance, or the US guidance. So it asks you to put in a few things. So let's just make something up. So echo available, yes, the echo is available. The ejection fraction, for example, is 27%. I'm just making this as I go along. NYHA class 3. QRS width, 140. This is how quick and easy it is. Left bundle branch block pattern, let's put yes. There's no history of arrhythmia, no history of sudden cardiac arrest. Syncope, not had any syncope. And these things, these appear on the UK guidance, they don't appear on the European guidance. This is just to tell me if I should be putting an ICD into high-risk other groups of people that don't necessarily have heart failure. And when I've entered that data, the data's only taken, 40 seconds to put in. You get a link to your local guidance. In this case, it's the UK guidance. And the UK NICE guidance would recommend for this patient a CRT-D or a CRT-P. And then it'd be up to clinician discretion to then decide whether we put a D in or not. The other thing about Screenlink is, if you're in a community clinic and your hospital, you're not in the hospital, or you're in a hospital that doesn't have a device clinic, you can actually generate a referral letter with all the patient information and then pass it on to your appropriate device people in the hospital. So I think it is a very useful tool, and I hope I've just demonstrated how easy it is to use. And I thank the technology team here at the conference for putting that in. When I went into the screen room, the slide room this morning, I talked to a nice chap, and I said, I'd like an internet link, and he went, oh, you're Williams Medronic Manchester, aren't you? I think they already knew about the fact that I was going to use the internet. So in summary, thank you for your attention. I think that new evidence over the past 5 or 6 years, and subsequently guidance, allow us to select the right patients who will benefit from device therapy. If you haven't looked at the UK NICE guidance, there is that table. I find that table very easy to use, very easy to remember. I think we've demonstrated by an audience poll that we're not very good at using technology. We've all got smartphones, we've all got tablets, we've all got the internet, and there are easy things that you can do on the internet. So I think that Screenlink, certainly in my practice, is a useful tool to make you remember the guidance, but also it may allow consistency and ensure adherence to guidelines in your local area. And I'd just like to wish Seville Football Club all the best. They are contesting the European League final on Wednesday evening. We'll have all departed on Tuesday evening in Warsaw, and I'm sure we wish them all the very best unless you're from Ukraine and you'll be supporting the other team. So thank you very much for your attention.
Thank you very much, Simon. And I think that you convinced us that we should use technology, and I know that Kenneth want to. I just Kenneth, let me ask just one question. This tool, which is of course very useful, and it's very easy to use it now with this the iPhones and the mobile phones in general. Is it useful more, you mean, for heart failure specialists, for cardiologists, for the GP? Where in the link of the patients with heart failure this should be applied? Yeah, so it's a good question. I think anybody who deals with heart failure can use this. So what we found in Manchester is that if we have patients who are relatively stable and they're in their community heart failure clinic, so they're not necessarily in the hospital getting followed up, and they go for their 6-monthly review, we may do an ECG, and we just double-check their medical treatment, make sure they're on optimal medical therapy, and then we could just put some data into Screenlink to see if indeed they require a device or we're not missing them to have the benefit of the device. So I think you're right. I think initially it will be used by cardiologists who are implanting devices in their clinics when they get a referral for, can you insert a CRT-D into this patient? But I think if you could use it in a broader spectrum, because it does allow you to generate a referral letter, just to make sure that we're putting the devices into the patients who would benefit, so to identify those patients. And I think the other thing that not just Screenlink does, but the guidance allows us to do is ensure consistency across the world in terms of who gets a CRT device. And just to continue with your comment, what is your opinion? Most of these heart failure patients at some point in their life, in their pathway, they will be hospitalized. Yes. Usually something that we always forget, probably is not the right time, but we usually forget, at least in several countries, to bring them these patients back or have them in mind if they have an indication for a device, for a CRT. Do you think is the right time to identify the patient, even use the program to identify these patients? Yeah, I think that's a really good point. I think, you know, the patients that come in, they have all their investigations, they have an up-to-date ECG and an up-to-date evaluation by a heart failure specialist, hopefully. I mean, we should all try and see our patients who are hospitalized with heart failure. I mean, the trial evidence really is in ambulatory outpatients, but this is a good time opportunity to allow identification of those patients who develop for device therapy, and we all do it. We all actually, just before discharge, once they've had the diuretics and their acute heart failure treatment, we may well embark on the insertion of the device before they're actually discharged. And I think that's, you know, even if we don't do that, we can identify them once they're a little bit more stable in the outpatient clinic to then receive the device therapy. So it's a really good point.
Oh, yeah. That was very interesting. I learned some interesting new things from you, that there are people with a sense of humor from Manchester. So that was an eye-opening experience for me. You know, I think it's important. I understand what you're saying. I think it's important that the message is incredibly simple. That those of us who are involved in CRT, we want to explore some new indications. We want to know, well, gee, if we can ablate this guy with AF and make him. But that message, it'll muddy the waters if it goes out. I understood that is this not primarily for primary care? Because that's when I tested it a bit to see how it was, and I understood at the time that was going to be the target audience. Yeah, well, I think anyone can use it, and I think if you are in a hospital clinic, we've said this before, and you're inserting a device, and you've got, you know, an indication where you think that's a CRT
P or D, and I'm not really sure, I think it takes you seconds to put the data into the app on your phone to just confirm, actually, my clinical judgment is the same as the local guidance. So I think you're absolutely right. I think it's probably more of a tool for primary care, but we use it extensively in our clinics in the hospital. I think it's a really good tool just to confirm that the device that you're putting in. And we mustn't forget, and I can't stress this enough, that you have to look individualised patient care as well. You can't apply blanket trial evidence and guidelines. It's very important to look at the patient in front of you. But I think it is useful in the hospitals, and I think it is useful with implanting physicians just to confirm what they're doing is the right way to go.
And also, it was the first time you used the term common sense to determine which type of device, a D or P. I thought that was fascinating, because the sense would not be common in this group. But it is an elephant in the room, and to make that decision, did you have, I know we're over time, but how do you decide? Tell us your common sense. You showed
common sense
age,
approach,
you showed non-ischemic or ischemic cardiomyopathy. Or
look at the state of the patient in front of you. It's as simple as that. And, you know, we have all this telemedicine and remote monitoring and all the rest of it. I like to see my patients. I like to see how they're getting on, even if it's just a 2-minute hello. So I think it's important to eyeball the patient. It's important to look what the kidney function is. It's important to look where their comorbidity is. Are they frail? How do they walk into the room? I think you've got to apply common sense, whether you're going to put, you know, a CRT-P or a D, because putting a defibrillator in somebody with heart failure who's advanced in age and has a lot of comorbidity is not without psychological things. And I think you've got to explore that with your patients. And I think common sense is absolutely key in managing people with heart failure. I really do.